I'm Brian Thompson from Commerce Bank. We're proud to be the presenting sponsor of this Worcester Regional Research Bureau's Forum on Charter TV3. At Commerce Bank, we feel we are an important part of the communities we serve, and sponsoring quality programming is one of the ways we show our support. Stop into any of our convenient offices. I invite you to learn more about Commerce Bank and how we can help you achieve your financial goals.
Welcome. My name is Tim McGurthy. I'm the Executive Director of the Worcester Regional Research Bureau. I'm pleased to be here to co-present this forum and this panel with the city's Department of Public Health, the Division of Public Health. And I want to thank Derek Brindisi, the Director of Public Health, and Dr. Hirsch, our moderator, who serves as the Medical Director for the Public Health Division. The Research Bureau's goal is to provide independent, nonpartisan research and analysis of public policy issues that impact the city of Worcester and the central Massachusetts region. And obviously, with all the discussion and debate and concern about Ebola and whether the public health capacity within the region can handle such a disease, we thought we'd bring a panel together and talk about what we can and can't do when it comes to not only Ebola, but infectious disease generally. We're very pleased and honored that we have our panel here. Dr. Anthony Esposito from St. Vincent Hospital, Dr. Rick Sacra from Family Health Center, and Mr. Moses Makor from the Worcester County Librarian Association. And as mentioned, our moderator is Dr. Michael Hirsch, the Medical Director for the City of Worcester Division of Public Health. I want to thank our sponsors. We couldn't do these free and open events without the help of our sponsors, Commerce Bank, Harvard Pilgrim Healthcare, Unum, Penta Communications, and all those who contribute both time and effort to the Worcester Regional Research Bureau. You can find out more in our annual report, which is available at the desk out front, as well as online at wrrb.org. I also want to thank the Telegram and Gazette, which is our media sponsor for each of our events. I will turn this over to our moderator, Dr. Hirsch. Dr. Hirsch is Medical Director of the city's Division of Public Health, Division Chief of Pediatric Surgery and Trauma at UMass Memorial Children's Medical Center, and Associate Surgical Director of the Trauma Center and Pediatric Intensive Care Unit. He formerly served as Principal Investigator of Injury-Free Pittsburgh from 1993 to 2000. His experience is in developing and applying innovative interventions to prevent pediatric injury. He's also a co-founder of Goods for Guns, a firearms exchange program. He designed and brought Safety Street to the Pittsburgh Children's Museum, a life-size outdoor exhibit designed to teach children the fundamentals of street safety. He received his MD from Harvard University in 1979, completed surgical residency at Columbian Presbyterian Medical Center, and fellowship training at the Department of Pediatric and Transplant Surgery at St. Christopher's Hospital for Children in Philadelphia. He's published extensively, won numerous awards, public service and teaching awards, and is board certified in general surgery, pediatric surgery, and critical care. So with that, I will turn it over to Dr. Hirsch. Thank you.
Thank you very much, Tim. It's a very kind introduction, and the nicest thing is that I'm probably the dumbest person on this panel as far as Ebola goes. Although I've learned a lot about it. I was in Liberia in 2011 with Rick Sacra at the time. I have some personal experiences there, so I'm very, very excited to have gotten such an august panel together, and all the credit goes to Tim for having selected this panel. I think that the Division of Public Health has really been enormously blessed with having great medical partners to work with when this crisis hit. The collaboration of the federally funded health centers, the free clinic system, the two main hospital medical providers, the emergency medical personnel has been very, very easy to coordinate for us. A lot of work, a lot of credit goes to Derek Brindisi, who you'll hear from later, our director, and Seth Peters, who's been the head of epidemiology and has been doing a lot of outreach trying to get to the same principles that we're going to try to talk about today, about the truisms about Ebola and some of the things that have been unfortunately exaggerated. I guess what I would say about Ebola is I remember last year Becker College hosted an event at Mechanics Hall in which they invited Tom Friedman, a very well-known political scientist slash journalist, op-ed contributor for the New York Times, Pulitzer Prize winner, whose famous book in 2005 said, "The world is flat." Now, he was referring to the fact that this was an economic globalization process where boundaries and economic policies of one country versus another no longer mattered because there was so much intermingling of commerce. But I think the world is flat when it comes to infectious diseases as well. And I think the medical community is starting to realize that we can no longer rest easily on these shores when health crises are coming to other shores. And that's, I think, the main take-home message that we're going to, I hope, leave with today, that we don't fall asleep at the switch when infectious diseases are knocking at the doors of some of our neighboring continents. It's not something that is their problem. It becomes our problem as well. And we have some wonderful folks to explain that a little bit more. I can tell you, I think it was in April of 2013, I was at a medical meeting out of the city when I had a call from Derek Brindisi that we needed some medical expertise on an outbreak of a particular infectious disease at one of our college campuses. And the two people that I called immediately were Dr. Leonard Morse, who's the former Commissioner of Public Health sitting in the audience, and Dr. Anthony Esposito, who is the Chief of the Department of Medicine at St. Vincent's Hospital and Chief of Infectious Diseases there. The amount of brain power in those two people is just astounding. And Tony is a world-renowned teacher, and I think will give us a lot of information tonight about really what Ebola is, and then we can take it from Dr. Sekra as to how it affects patients, because he's seen it firsthand, unfortunately, as a caregiver and then later as a patient himself. And Mr. Moses McCord is a nurse, also works at St. Vincent's Hospital, but has been very involved in helping the Liberian community cope with the crisis on these shores and across the ocean. So I think that you'll find in this panel a tremendous depth of information that we can mine tonight, and hopefully there'll be a period of question and answer. So we want this to be kind of conversational. Tim was kind enough to set this up kind of like a living room, so hopefully you guys will feel comfortable enough to ask the questions, and we'll field them. So without any further ado, I'm going to ask Dr. Esposito to come to the... Okay. Thanks so much, Dr. Esposito.
Thank you for that very kind introduction. My job will be to discuss the epidemiology of Ebola. What's the epidemiology? How the disease spreads. How the disease spreads. The story of Ebola really began in 1976 when there was a remarkable outbreak of a hemorrhagic febrile illness in northern Zaire. Blood from some of the patients was sent to researchers in Europe. The scientists in Europe looked at the blood under electron microscopy and observed a remarkable virus, something that had never been seen before, both in terms of size and shape. Those scientists went to Zaire to help to control the outbreak and, in fact, eventually named the virus after a river near the village that was primarily impacted by the disease, the Ebola River. The current problem is in West Africa, as indicated by the map. This is, again, the electron microscopic picture that they saw, the first images of the Ebola virus. They, in fact, brought some of these photos with them to help show people what was causing this terrible and fatal disease. I might also point out that they made observations about the transmission that were important. In particular, in a hospital in the primary impacted area, patients were being injected with needles that had been used in other patients, highlighting the importance of blood as a vehicle for transmission. Now, since 1976, a tremendous amount of research has been done on the virus. Its structure is extremely well understood, and this schematic outlines the various components of the Ebola virus. So scientists understand how it attaches to cells, invades cells, replicates in cells, injures cells, and exits cells. One of the important structures on this schematic are these little projections, these spikes. These spikes represent targets for antibodies. You probably heard on TV about ZMapp, which is an antibody directed at these spikes to help prevent the virus from attaching and invading. These spikes will represent components of vaccines that hopefully will obviate the disease in the future. In addition, by understanding the molecular function of the virus, drugs are now available that, at least in some circumstances, impair the replication of the agent. Now, since 1976, other Ebola viruses have been identified. However, the Zaire virus is clearly the most virulent and associated with the highest case fatality rates. This map illustrates other outbreaks of Ebola that have occurred between 1976 and 2014. Each of the brown dots represents an outbreak of disease. The larger dots represent 300 or more cases, the smaller dots, smaller numbers of cases. The other colors represent outbreaks due to other Ebola viruses. The point is that outbreaks have occurred and will continue to occur for reasons that we will mention. The current outbreak was first recognized in March of 2013 and was centered around this city, Gekadu. Now, one of the reasons the current outbreak in West Africa is so extensive is that although the World Health Organization acknowledged and recognized the outbreak in March, by doing genetic analysis and other epidemiological studies, it was clear the outbreak had actually been going on since December. So the outbreak had been unrecognized, leading to clusters and expansion of the disease. The other factor which contributed to the spread is illustrated by the road. In fact, most prior outbreaks of Ebola have occurred in extraordinarily rural areas. Where there are roads, there's the potential for transportation. Movement means the potential for dissemination. This is from the CDC website showing, as of last week, the number of cases that have been identified in West Africa. What I'd like to highlight are not the cases in West Africa, the 14 to 15,000, but the fact that cases from West Africa have been exported to neighboring countries like Senegal, have been exported to Nigeria, and yet in those areas the disease has been controlled. The point really is that by doing very basic epidemiological control, infection control, by instituting infection control policies and procedures, these diseases, the infection can be controlled even in the most primitive or rural countries, which should make us here in the United States extraordinarily relaxed about the problem. A few cases have appeared in Mali, which is contiguous, but again, it's not likely the disease will spread extensively because basic infection control practices that we'll talk about in a minute have been put into place. Now, frankly, I was a little nervous about showing this image. But the primary reservoir for Ebola in Central Africa is the bats, certain fruit bat species. These bats carry the virus but are not killed by the virus. The virus is spread from the bat to other animals living in the tropical forests there. From the animals to humans. And the somewhat grisly slide illustrates two things. A human being who has contact with an animal or another human being's blood direct contact is obviously at risk of becoming infected. Contact is necessary. What does contact mean? Contact means if I touch infected blood, if I touch infected feces or vomitus, and I have a break in the skin of my hand, I might pick up Ebola. If I touch blood, if I touch feces, if I touch infected vomitus and touch my eye, I might acquire Ebola. If I have no contact with those infected body fluids, I'm not going to get Ebola. And this simply illustrates, again, the fact that direct contact with the infected material is necessary for transmission. How catchy or how communicable is the disease? Well, these are data taken from some of the earlier outbreaks. In the initial Zaire outbreak, about 5 or 6% of all contacts with patients with Ebola became infected. About 15% of people who had a lot of contact with cases became infected. Now remember, this is an area which has maybe no running water and no sewage. So this is not a Western environment. Secondary attack rates are not extraordinarily high. Similar observations were made in an outbreak in the Congo. Again, about 16% among household contacts, no cases without physical contact. In 1996, a physician with Ebola undiagnosed was admitted to hospital in South Africa. South Africa is a sophisticated country. That individual recovered from his Ebola. One provider who helped put in a central venous catheter became infected. The disease wasn't recognized. The point is about 300 providers had contact with two patients with Ebola, undiagnosed. One became infected. And this was not using the full PPE, personal protective equipment, but using standard precautions. You wash your hands, you use gloves, that sort of thing. The illness usually begins about a week or so after the initial infection. The word exposure is commonly used in medicine, but it isn't exposure, it's the initial acquisition of the virus. During that first week, people are well, the disease is not transmitted. Usually about a week or so after the acquisition, patients become quickly ill, and fever, chills, severe headache, etc. During this period, there's virus in the blood, and there's virus in other tissues, but as long as you don't have contact with that blood, you'll not acquire Ebola. A couple days further into the illness, nausea, vomiting, and diarrhea. Diarrhea and vomiting of enormous volumes are characteristic of the problem. That vomitus, that diarrhea is infectious. The volume loss associated with vomiting and diarrhea contributes mightily to the case fatality rate of the illness. Now, what should be reassuring to everyone in this room regarding Ebola in the United States is actually the sad story of Mr. Duncan. Mr. Duncan comes to the United States. He's well. He develops, 4 days later, the fever, the headache, and goes to the emergency room. He's evaluated there. He has bloods done. He has chest x-rays done. He's examined there. A diagnosis of who knows what is made, and he's sent on his way. 2 days later, he's taken by ambulance back to the hospital. He had direct contact with about 80 individuals prior to the diagnosis being established. None of those people became ill. Who became ill? 2 of the healthcare providers who cared for him during the most serious stages of his illness. Why? Well, let me put it to you this way. Before Mr. Duncan, every hospital had a had a process for dealing with infection control that was adequate to the diseases the practitioners encountered day in and day out. Not adequate for this disease. Since Mr. Duncan, hospitals now are becoming prepared. Another way of looking at it is patients with Ebola who've been treated in Nebraska, who've been treated in Emory, who've been treated at Bellevue in New York, who've been treated at the NIH, have not transmitted the disease to any of the providers. The point is training and training and training of the healthcare providers is essential when dealing and having direct contact with a seriously ill patient. Now, this equipment is necessary if you're caring for a patient who's bleeding, throwing up, and having diarrhea. If a patient with Ebola were to walk across the auditorium here, he or she would be of no risk to anyone in the room. And with that, I'll close, and I'll be happy to entertain any questions you might have when we have the panel discussion. Thank you very much.
Thank you so much, Dr. Esposito. That was terrific. Our next speaker has some very, very personal reflections, I'm sure, about Ebola. Rick Sacra is one of the real heroes of the medical community in Worcester and in the United States. He's devoted years of his life for humanitarian work in Africa. I had the pleasure of first meeting him when he was a medical student, when I was a young ped surgery attending. I was once a young ped surgery attending. I was always very impressed at his inquisitiveness, even at that time. I saw him again in 2011 when we were both in Liberia. He was an old hand at visiting Liberia, and so he kind of filled me in on some of the do's and don'ts, and it was a very helpful primer on how to get through a week or two there. As you all know, he contracted Ebola during one of his humanitarian missions there and ended up getting flown to Nebraska for his initial care. And we're all delighted to see that his recovery has been so robust, and he's back to full strength, and his wife and son are here tonight, and we're very happy that they're all together again. So I'm sure that Rick is going to give us his insight as a provider, as a patient, and as a humanitarian. So we're very grateful that he came tonight.
Thank you. I have worked in Liberia for 15 years or so, lived there. My kids grew up there. I serve with an interdenominational mission agency called SIM, and I work at a hospital just outside the capital city of Monrovia called ELWA. For the last 15 months or so, while we've been based here in the States, we have kids in high school and starting college and things like that. So we need to be here right now, and I've been making trips over for about 4 weeks at a time. As Dr. Esposito explained, the Ebola epidemic was officially recognized anyway in March. I will mention just that from a cultural standpoint, most people feel that over half of the cases, especially early in the epidemic, were caused by funeral and burial practices. There's a tradition of washing the body and dressing the body before burial that family members often take part in. This is a part of their culture. They feel it's their duty. It's part of their grieving process. So that has been hard to modify and hard to change. It's really a deeply held cultural belief, and a lot of the cases have been related to burial practices. ELWA Hospital started to get ready fairly quickly. Once the epidemic started, we knew that with an epidemic happening at the border with Liberia, it wouldn't be long before somebody got in a car and came to the capital. And so we actually converted our chapel at the hospital. It was the only space we had that we could easily modify into an isolation unit. So we converted our chapel into a 6-bed treatment unit for Ebola patients. That stayed empty for a couple of months, but then started getting used in June. By July, the cases were mounting up, and we were requested to, in fact, host a second treatment unit on the compound, even as we were expanding ours to meet the need. Doctors Without Borders was looking for a place to put a treatment unit, and we offered them space on the other side of our 100-acre campus there. So for the first 3 months or so of cases in Monrovia, all the treatment for Ebola was happening right at ELWA, whether sponsored by us or by Doctors Without Borders. When I arrived for my trip in August, the situation was quite desperate. All hospitals in Monrovia were closed at that time because each hospital had had either a physician or some nursing staff come down with Ebola, and then they had to close the facility in order to decontaminate the place. Many staff were were afraid to come back to work, were very concerned about their own safety. Personal protective gear was not readily available at that time. And so you had a situation where a population of about 1.5 million people, which is, just think about Worcester County and double it, basically, had no healthcare facilities open at all. And so you had pregnant women with nowhere to go, a woman with an obstructed labor who needed a C-section, absolutely no place to go to get help with that. A child with malaria, no place to go. And this is one of the things that is very important to recognize, is that this Ebola epidemic has ripple effects, has had repercussions, aftershocks into society as a whole and into the healthcare system that not everybody recognizes. We can't just focus on dealing with Ebola. We have to look at the whole health system. So we took care of a lot of, probably about 40 pregnant women during August. Most of them required C-sections. Unfortunately, a majority of them had babies who had already died within the uterus because they'd been out there in labor for sometimes over a week. Coming along up to the present day, now I haven't been there since September 1st, but we have colleagues who are there at ELWA. Gradually, we've been able to reopen the hospital. In other areas, the clinic is now open, taking care of kids, taking care of adults with chronic diseases who need to come in for a checkup. So those spaces are open now, as well as sick adults and kids who need to be admitted to the hospital. It took time to do that because our whole system of doing triage had to change. We had to kind of modify the structure of the building so that everybody could come in through a single entrance and be screened, figure out who could come into the hospital, who needed to go to the Ebola treatment unit, those kinds of decisions, whereas we used to have sort of multiple entrances. You could go into the lab or go into the emergency room, and we couldn't have that once we were dealing with so many cases of Ebola. I developed a fever on August 29th. I was concerned immediately that it might be Ebola. I isolated myself. I contacted my family. I contacted our medical director over the course of the next couple of days. We observed it. On the third day, we did my blood test, which turned out to be positive for Ebola. I'm very grateful. The team in Liberia at the ELWA treatment unit did a wonderful job. I went there, I got IV fluids and hydration and other medications that they gave me that really helped keep me going. I'm also very grateful to both the State Department and others, SIM at the mission, who worked out the details of getting me evacuated to Nebraska, and the treatment there was terrific. One of the questions that people ask me is, what are the differences? Why does the survival rate appear to be pretty good? We're 8 out of 10 so far here in the U.S. and for survival, and usually the survival rates quoted in West Africa are somewhere around 30 to 40%. Why such a difference, people ask me. And I think there are several reasons. One is, although you can get IV hydration and sort of supportive care in the West African setting, none of the Ebola treatment units have lab facilities for monitoring. And so you don't get your potassium checked or your magnesium checked or those kinds of things. You can't do that fine-tuning that you do here. The second thing has been the medications. All the patients in the U.S., I think, have all received one of 3 different experimental or research medications. And there is good news on that front. All those companies that make those medicines are all in West Africa right now, working out the details. You know, each country has their Ministry of Health. They have their own guidelines and protocols for how to do a clinical trial. So it's not something you can just walk in and say, we want to start using this medicine here, no more than you could here in Massachusetts. You have to get the necessary approvals and file the necessary applications and so forth. So that process is going on right now. I'm hearing that they're getting ready to start some trials fairly soon, hopefully. And the other factor is this convalescent serum, where people donate blood for somebody else. People who are survivors of Ebola donate blood. And that has happened on an occasional basis in West Africa, but I don't think it's happening. Not all the patients are receiving that. And that, too, is being set up as a clinical trial. And I think if there's good data that proves that it works, then we'll be able to get an arrangement going where people will be able to come in and donate plasma to give to people who are ill with Ebola. And that too, is in process of being studied. Unfortunately, science is painstaking and takes time, and people have to pay attention to the details. And the Ebola crisis, unfortunately, has been unforgiving about the time delays, and a lot of people have lost their lives due to that. But this is, it's a difficult disease to study because it has these little brief epidemics, and then it goes underground for 4 years. So if you're an Ebola researcher and you've got a drug ready to study, how do you figure out which country to get the approval from? You don't know if it's going to pop up in Congo or Uganda or Sudan or where. So it's been a tough disease for the drug companies to really get those things going. So they're working on that. So in conclusion, I would just like to say, first of all, I'm very thankful for my life, and many people were praying for me, and I appreciate that. I also appreciate the excellent care I received, and I'm very thankful and grateful for that. There's still a very high rate of diseases in West Africa, of cases in West Africa. Right now, it seems that the situation in Liberia and Guinea is a little more stable. The situation in Sierra Leone seems to be getting worse. So we need to continue to push, and both sending volunteers and materials that are needed there, funding that's needed there to get this thing under control. And secondly, let me just again say that we need to focus on the whole health system. Even when Ebola is finished, when the last case has passed, there's going to be a desperately weakened and very a health system that really needs support, especially in the form of training, so that we can raise up another generation of doctors and nurses who can take the place of some of those who've been lost. Thanks very much.
Thanks very much, Rick. So our last speaker today, before we get to our panel discussion and Q&A, is Mr. Moses McCord. Mr. McCord has been a very, very important member of the medical liaison community between the Liberian community, which we are very blessed in Worcester as having up to 6,000 members, and the medical community. Mr. McCord was an immigrant himself to Worcester in 2000 and became a U.S. citizen in 2005 and received his Bachelor of Nursing degree at Worcester State College in 2007, and he's currently pursuing a master's as well, and has been working at St. Vincent's as a staff nurse, but in the meantime has been working on some very important programs to represent the Liberian Association of Worcester County. He's the chairman of their Ebola crisis response team, and he's also founded an organization called the Diaspora Nurses Health Initiative. So we're hoping that in hearing Mr. McCord today, we will get an insider's perspective of how this has affected the Liberian community here and the Liberian community back in Africa. Worcester has enjoyed a reputation as being the #1 refugee city in New England, and the diversity that it's brought to our city has been well documented and is an incredible resource to making us the kind of melting pot that we used to hear about New York City being and some of the other big cities around the country. I know when Tim was the head of the Office of Economic Development for the city, that this was really very attractive to businesses coming to the community, and we look at this community as a very important part that needs to be built up and supported, and we want to hear Mr. McCord's thoughts about where we can help and how we can make a difference. So, Mr. McCord.
Thank you, Dr. Hirsch. Thank you, Dr. Esposito, Dr. Sekra. Thank you so much. Whenever I see Dr. Sekra, I feel a sense of guilt on myself as a Liberian to be in Worcester and not being there in Liberia. But sometimes I feel like Dr. Sekra knows more about Liberia than I do. And I try to be American, and he's more Liberian than I am. I told him a story of an aunt who, when I visited Liberia last year in July, she didn't go to school like some of us did. So I tried to speak my indigenous language, which is Pele, and she was speaking English back to me. So Dr. Sakra is that aunt of mine who I'm speaking American English to him, and he's speaking typical Liberian English. But I'm grateful to be on this panel tonight. I'm very grateful to Derek Brindisi, who put me out there to be on this panel. Dr. Hirsch, I'm very grateful to you and to the Worcester Regional Research Bureau team. I'm grateful to you for having me here tonight. I think what happened is that as a Liberian, like Dr. Hirsch said, I've been a resident of Worcester County since 2000. We felt the need to come together and create some awareness out there about the Ebola crisis, more so with what is going on, the social aspect, the stigma that is associated with the disease. We felt that as Liberians, there was a need for us to be in the forefront, even though we were unable to be in Liberia to help with the situation there. Folks in Guinea and Sierra Leone, I'm sure, have their folks back in their respective countries helping out there. So I just want to quickly go through some slides here and address the psychosocial aspect of the epidemic that's been going on. The photo out there is a child, probably about the age of my son, who's sitting in the back. So the child is in a classroom. Unfortunately, when this epidemic was at its height in Liberia in September, kids were to go back to school just like kids in the U.S. started going back to school. And many of these children had no classroom to go to. And like Dr. Sekra said, this is just one of the aspects of the disease. Locals in West Africa, the communities that were affected, or the countries that were affected, somehow had the misbelief that the virus was imported from the West, which isn't true. Like Dr. Esposito has said, we know the source of it. But there were a lot of mistrust among the healthcare workers. And so other than the barrier practices that Dr. Sekra alluded to, the high death rate amongst healthcare workers also propelled the disease, because at a local level, if a nurse is coming to you or doctors are coming to your village, and many of them, you're hearing stories of nurses or doctors are dying, the locals were shunning those healthcare workers, so that also helped the disease to spread out. And of course, there has been rumors about past vaccinations. We know of stories in Nigeria and other parts of West Africa where the polio immunization really received a back push because people felt it wasn't helping the locals. So some of those factors also helped to spread the epidemic, as we saw in West Africa. There is a town, a suburb, actually it's a slum of Monrovia, Dr. Sekra, that's West Point. The president decided to quarantine the area, and we've heard about quarantine and how ineffective it is. So the president actually quarantined the West Point community, and is an area that probably has about 50,000 residents. And so there was a revolt against the police and against the government. As you see, there are police officers trying to barricade folks from leaving that area during that time. The impact of Ebola culturally back in Liberia and here, or in West Africa, amongst those three countries, Sierra Leone, Guinea, and Liberia. I'm focusing mainly on Liberia because I know a lot about Liberia than those two countries. There's been a lot of discrimination. There's been a lot of stigma associated with the illness, blame, and death. Unfortunately, the baby is alive. Her mother is struggling from the illness. And when the epidemic was at its height in Liberia, a lot of people, other than what ERBA and other treatment centers were doing, a lot of centers were turning away folks from those centers. So the picture out there is a mother who is ill, stricken with the virus, but has nowhere to go. And her child is lying next to her. And a lot of communities, the stigma associated with the disease, even healthcare workers that are working in those areas, some of them were being prevented from going back to their community, or they weren't returning because people are no longer opening their arms to them and receiving them, because they felt if you're a healthcare worker, you are at high risk of contracting the illness. So if you went back home, chances are you may import the illness back to your community. But that's just the stigma with the healthcare workers. But the stigma associated with the illness as Liberians and as West Africans is that you walk out, a lot of folks were beginning in the West, are beginning to see people from these three West African countries are people who possibly could be carriers of the virus. And so we in Worcester County, we've organized ourselves to create the awareness out there. And a lot of Liberian communities around the country also have been working to reduce the stigma. We've heard of stories about schools turning away West Africans, or landlords probably refusing to rent out their units to people from West Africa, and this isn't good. Like Dr. Esposito said, we know how Ebola is transmitted scientifically. It's been proven that Ebola is transmitted when someone is heavily infected and you come in direct contact with bodily fluids, as we learned tonight from Dr. Esposito. But the stigma is what we've been trying to help. That's a letter from the Navarro College. It's in Navarro College. So a Nigerian student, we know there were 8 deaths in Nigeria, but Nigeria is no longer one of those countries that is on the map of Ebola because they're clean. But that student applied to a college, and he was turned down only because the college decided that the would refuse application from international students from West Africa. So what we're facing as people of those countries is these kinds of stigma associated with the disease, which isn't right. I think we need to really listen to the scientific community and listen to our doctors and listen to our experts and hopefully learn from what they're telling us other than us making up assumptions in our communities or at community colleges. Ebola is having a very lasting effect on communities, West African communities. Families are separated. Families are unable to care for their loved ones. Dr. Sekra is a living testament to that. Liberians typically, we're people who love our family members. We love to care for one another. So to see a family member who is stricken with an illness at their most need and being told that you're unable, you cannot take care of that person breaks the heart of people. It breaks the heart of our folks back in Liberia and for us here, because we're separated from them. We're thousands of miles away. We have to get on a plane to get back home. And for our own safety, especially for folks who are not healthcare workers, they're unable to go back home to care for their family members, their dad, their moms, or other relatives. And even in Liberia, there are children who are being made orphans. According to aid agencies, there are over 500 orphans right now amongst the 3 countries. And so already like Guinea and Liberia have emerged out of civil war, years of civil war. And so with kids being made orphans, that's just causing more problem in those countries. And I'm just going to quickly show you some slides of children. This is a child pulled from the BBC, courtesy of Plan International. So his name is John, and he's from Lofa County. That's the northern region of Liberia. He lost his parents to Ebola, so he's an orphan. The 2 children, they are also, Sia is the older sister, and that's her younger brother. They both lost their parents from Ebola. She's from Bombing County, which is closer to Sierra Leone. Now, Liberia, the first reported case of Ebola in Liberia, the report is that the person who brought in the virus through the road that Dr. Esposito, the road that was shown to you, the person came from Sierra Leone through Cape Mount and Bombing County. So that's the western part of Liberia, and it's more closer to Sierra Leone. Another picture of a child or 2 children, Miata. She's caring for her younger brother. They've both lost their parents from Ebola. And I read the caption of this child, Musa. The caption is that he sometimes has to fend for food from the churches. In order for him to eat, he has to go to a church to eat. So he's carrying a well-worn Bible in his hand from the church, and that's how he's surviving nowadays. And Fatu is the oldest of the children. She's 28 in the upper right-hand corner. She's also the one who has to fend for her family because they've lost their parents to the disease. This is the only picture of their father and their mother. They both died from Ebola. That's the last remaining memory they have of them, the National Elections Commission photo card. So Ebola is affecting us culturally. Dr. Sekra told the story of him arriving in Liberia, and he went to give a handshake to someone, and they told him, hey, you cannot shake my hand. And being used to the Liberian culture, Liberians will embrace, will shake hands. And so in those countries, they can no longer shake hands, they can no longer embrace because of the fear of contracting the disease. So it's really culturally, it's affecting how people interact with one another. So those folks, they're doing the Ebola greeting, which is, you have to be separated from the other person. So, I mean, kissing is a taboo, hugging is a taboo. It's affecting how people relate to one another intimately also. In isolation units, what we're seeing, what our families are telling us is that they feel abandoned by their loved ones. Because once you've been diagnosed with Ebola and you were taken to the Ebola treatment units, you're pretty much in that unit by yourself and your family members cannot interact with you. So the government came up with a scheme where folks were given cell phones to communicate to the outside world, so to speak, with their family members. And so, like I said, it really breaks the heart of people to do that. And another issue that folks are facing while they're in those treatment wards is the fact that they feel they are being taken care of by total strangers, because with the PPEs that Dr. Esposito alluded to, you see that it's difficult for you to see the face of the person who's working with you. The waiting to know syndrome was coined back in Uganda. It's a 21-day period where you are, once you've been suspected of carrying a disease, you're waiting to see if you've been affected. And so that syndrome, the waiting to know syndrome, is what a lot of people are going through. I actually have a friend of mine who works on the Ebola crisis response here. Her husband moved to the United States before the outbreak, and his ex-wife got infected. Their child was suspected of carrying the disease, and she was actually in an area where there was a nurse caring for her because he decided she was 5 years old and he wouldn't put his daughter into a treatment unit. So he had her home, and there was a nurse whose responsibility it was to care for her. Fortunately, the child survived. The child is okay. She did not have Ebola. So it's impacting people. Dr. Brantley, in the picture there, he also talked about masked men treating you, not knowing who's caring for you. Ebola is affecting our folks back home. I have children who, when I was back in Liberia, I took upon myself to try and help them. It's very simple. It's very easy to care for folks, children in school. But schools have been suspended in Sierra Leone. Liberia saw a definite closure with the lifting of the state of emergency in Liberia. There is talk about possibly reopening schools in January, but think about it, schools were closed in the middle of summer and schools been closed since, so our kids are around, and unfortunately, we don't have a situation in Liberia like the United States where we have public libraries that are equipped to care for the children, so these kids are roaming communities without learning. One of the impacts of Ebola. And not only that, but kids that are even coming overseas are being rejected. There's a story of a British aid worker whose son was rejected at school in the UK. I'm talking of someone she's a British citizen, but she brought her kid back to her local community in England and she was rejected. And so we're seeing a lot of xenophobia out there. So we're hoping that forum like this, educational forum like this, and others that are being held, I believe, around the country will help break down these barriers. And so as not to put us in a class that we don't deserve to be in. Like Dr. Hirsch said, Worcester has been very hospitable to many of us. My education was acquired here in Worcester, and so many other Liberians and Sierra Leoneans and Guineans. So we give a lot of credit to Worcester and so many other communities around the United States. But with the outbreak of Ebola, we're beginning to see some shifts in the sand. So we're hoping that we can re-cement the relationship or the hospitality that we've all been given. Some of these things we've talked about, the increased scrutiny of us, travel ban, which we hope, thank God that the government did not institute that. There was a lot of clamor for travel ban. And the case of Casey Hickox from Maine, I think shed a whole lot of light on this virus for us. Sometimes out of the worst of situations, God is able to bring the best. Her case also help us out as West Africans in the United States. So is the case of Dr. Sekra and other cases that were brought back to the United States. I think these cases also brought the best out of it for us from West Africa. Dr. Sekra is the best person to talk about the impact of the virus on our healthcare system. Or prior to the outbreak of the virus, the healthcare system was next to nothing. UMass and other partners have been helping to rebuild our healthcare system in Liberia by sending over medical doctors and interns, but with this virus now, it has taken a toll. Many of our doctors have died from it. So we definitely need to help rebuild our healthcare system. Barrier and cremation, our folks, we're not used to cremating. Cremation is not our culture. Barrier, caring for our dead is what we do. So, I mean, the impact of having to cremate folks is taking a toll on our culture also. We're hoping that with the meeting of President Obama of the nurses from Dallas that recovered, and these kinds of meetings are going to help to reduce some of the stigma, reduce the discrimination that is associated with the virus. Just want to say thank you for giving me the time to present and listening to me. Thank you.
So I know in the interest of time, we were going to kind of separate a little panel discussion from question and answers, but I don't think the panel would object to kind of combining those sessions, and we can start the conversation up here amongst us or generate questions. Jean is kind enough to be acting as Phil Donahue in the audience here. She will get you a microphone, so raise your hand and we'll be happy to answer any questions.
Hi, very interesting. I'm enjoying this. I like science. I'm actually an NP as well. But my question is, the two nurses in Dallas and Mr. Duncan, obviously Mr. Duncan passed away. You do read things about fatal versus non-fatal Ebola. Besides the obvious of a person dying with fatal, is there a subtype difference? I know there's those five subtypes that were there that causes more virility for Mr. Duncan to die, or is it related to host resistance and host ability to fight the disease, or is it related to viral loads? I just find that kind of fascinating as to why some people do succumb over and above the obvious of not getting the supportive care like in some of the remote villages in West Africa. Thank you.
The science in terms of susceptibility to a fatal outcome is really just beginning to be understood. In the current outbreak, higher fatality rates are associated with people who have higher viral loads. What does that mean from a genetic point of view, a pre-existing immunity point of view, an ability to generate an immune response point of view? That is unknown. I would say this, that in general in infectious disease, once a patient passes the physiologic point of no return, then therapies are ineffective. In other words, the people who have succumbed to the disease in the United States, from my point of view, were treated with optimal therapy late in their illness. Now, if they had been given therapy earlier, would they have survived? There's no way of knowing, there just aren't the data. But more likely than not, they would have. The ability to treat viral diseases is, there's a long history for it, whether it's passive immunization, antiviral medication, plus supportive therapy. Those things all need to be instituted early and before the patient has such physiologic derangements that the interventions really make no difference. So it's not a useful answer, but because the information simply isn't there to answer your question intelligently.
I will throw a question out because I think certainly I at least want to get it out there about some of the controversies that have occurred with care of Ebola patients here in the States. Though I'd be interested in the panel's thoughts about the self-quarantine issue. I know Mr. McCord brought up Casey Hickox, Dr. Spencer from New York, who was treated at Bellevue, who didn't isolate himself and ended up making some trips into the subway, et cetera. What should health workers, because we're very, very fortunate that I think our own academic institutions in town have made a major commitment to support Liberia. Jim Leary is here from UMass. We've had a major grant and commitment to continue to send experts in pediatric, emergency medicine, family medicine, obstetrics out to Liberia, especially in the face of this crisis of healthcare workers being infected there. And I wonder what we should be recommending for those workers coming back.
The situation with Dr. Spencer, you know, I think it's unfortunate that, you know, there were all kinds of headlines when he was ill in Bellevue. I guess there's a couple questions that I had. One was, what about the inconsistency? You have healthcare workers in an American hospital dealing with an Ebola patient. They were not under any sort of restriction, but a healthcare worker who was in Africa and now has come home is put under a rather restrictive quarantine for 3 weeks, when they both really have similar, you know, I mean, most of the people who are working in Ebola treatment units now have access to a full suit of protective gear. They're working in similar situations. Obviously, U.S. healthcare workers are not entirely immune. We had 2 of them get sick in Dallas. So those are inconsistencies. There were lots of headlines at the time, you know, oh my gosh, he went on the subway, oh my gosh, he went bowling. We're all, you know, and yet there isn't much talk now that, well, gee, let's look back at all those people. No one has come down with Ebola. No one on the plane with Amber Vinson. No one who, not even his fiancée and his close contacts, let alone people who ate at a restaurant with him or went bowling with him, but his 4 closest contacts, none of them got ill, Dr. Spencer's. So, you know, I think the point to be made is that monitoring is effective, because monitoring, if there's close monitoring, you get to know when the person has a fever, they're not infectious, they can't spread the virus to other people until they're ill. And that's something we feel we know pretty well. And now there's a whole range of things between the restrictive quarantine that they tried to impose on Casey Hickox and what Dr. Spencer was doing. There's a whole range of options in between. You can have a telephone call twice a day with a public health nurse. You can even have a visit from a public health nurse twice a day to check a temperature. Some states are restricting certain types of activities. They're saying, we don't want you to go on public transport, but they're letting them out of their home and into, you know, they can go on a walk, they can go to a restaurant, they just can't go to on a public transportation, you know, venue. So there's lots of gradations in the middle that are less restrictive and more reasonable than the complete closed up in your house, you can't leave the home quarantine. And I think we need to look at, well, where's the right balance? You know, I think in general, self-quarantine is actually safe, but obviously there's a certain amount of public sense of we want more than that, we want better monitoring than that. Well, I think we can look at options for public health monitoring that will meet some of those needs if it's needed. I'm very thankful for Massachusetts. Massachusetts has been fairly trusting and kind of recognizes that, hey, these are healthcare workers. They know how to check their temperature twice a day. They can report themselves, to authorities when they need to, and so I'm very thankful for that here in Massachusetts.
Let me add that there's the science of the disease and the fear of the disease. And for 5 months, the U.S. public has been bombarded with images of what? People dying in the streets with Ebola, people dying in the gutters. That's their image of the disease. And so naturally, the fear tempers everyone or distorts everyone's thinking on the matter. Unfortunately, for example, we don't have a Surgeon General, right? If we had a Surgeon General or some other reasonable health authority that could perhaps influence the thinking of political leaders, perhaps some of the fear could be mitigated. But the fear now really drives. So the healthcare worker returning should feel comfortable going bowling, having dinner, having a pizza, going to the Pats game, doing whatever. However, that person has to understand that the people in his environment in the U.S. are simply afraid. And that's a powerful factor.
I've heard Dr. Moore say that you can't take the public out of public health, and I think that part of the public's misunderstanding has unfortunately been driven, without offending any of our media colleagues in the front row here, by the media. And I wonder, if a lot of what Moses is talking about, this stigmatization, doesn't come from the constant drumming up of this, fever pitch kind of, oh my gosh, what's happening? So I wonder, Moses, if what kind of counter messaging? I mean, you presented such a calm and kind of reasoned outline of the suffering of Liberians in your country and on these shores. That should be as compelling a message as any of these hysterical ones that we get. How can we get your message out?
Well, I think primarily what we need to do is to, like I said, not to sound like an old record here, but to listen to our experts, listen to our scientific experts, the scientific community. I love the press, but the press is like a tiger. You ride on it, but sometimes it ends up eating you up, right? Dr. Nancy Snyderman, we all know her. She's the NBC News chief medical correspondent. So she was in Liberia for some time reporting on the outbreak, and when she came back after the cameraman got infected and the team flew back to the United States, she was ripped in the press for leaving her self-quarantine and showing up at a deli or something of that sort. And but she's a trained medical doctor. She knew what she was doing, but the press wasn't happy. The public wasn't happy with what she was doing again, because they felt she should have been indoors. She should not have left her home. She should not have driven her car out of a driveway. And so what we're saying is that these kinds of messages are wrong. What we need to do is to send a message out there that the virus can only be contracted by someone who is gravely ill and who is symptomatic, and only if you come in close contact with this person, as opposed to saying that let's quarantine everybody, let's make sure that all of these folks are locked up, or let's make sure that if you're from West Africa, you're no longer needed in our schools, or you're no longer needed in our communities. It's wrong. So the message out there is that we have to educate our public, we have to educate our communities, and let them know that Ebola is real. But like Dr. Esposito said, the media has done a very good job on playing on our minds and making us to feel like Ebola is going to be all over in our communities in the United States. Fortunately for us in the United States, we have one of the best, if not the best, healthcare system in the world. And we've got experts in various diseases that are well knowledgeable about how these diseases are transmitted. Infectious disease is out there, but we have infectious disease experts in our midst who are telling us, who are educating us daily. So we just need to let our public know that we need to listen to them.
Could I ask, one thing that you can hear from the panel, which is phenomenal, is that Worcester is very connected into this broader world where Ebola happens and where, as the world is flat. So what would happen locally if someone did come back to Worcester and then manifest the disease? How does the medical response occur here locally?
Every institution in the city, most schools, most public health entities, clinics, et cetera, are now trained to ask the question, have you traveled within the past 21 days, and where have you been? Do you have a fever? If the answer to those questions is yes, virtually every institution is trained to put that person in the room, close the door, and call the Department of Public Health for guidance. So I think we're in an excellent position to recognize a patient with possible disease. We're so good at it that I get calls night and day. I got a call the other day about someone who had traveled to Morocco and eaten fruit. And I thought, why? Because Morocco's in Africa, and fruit bats, right, contaminate fruit. So what did I say? I didn't say, we're going to send this person to an Ebola treatment center. I said, the person's at no risk, treat them evaluate them for their febrile illness. But the point is, the level of awareness of risks is so high now that people are being screened very adequately. Now, all of the hospitals have, in their emergency room, staff now trained to take a patient who would be at a high risk of having the disease, put them in a room that's appropriate for their care, have the appropriate equipment on, and institute an Ebola response that would include an assessment, contacting the state DPH, and doing testing there or transferring to a currently designated Ebola treatment center. At present, UMass is not, but they will be very shortly. The current ones are in Boston and in Springfield. So most institutions now have very good plans. The plans are quite solid because of what happened in Texas. Nobody wants to have a situation like that. So I'm very comfortable that we'd be able to recognize the case and institute appropriate initial assessment and do appropriate triage to a facility where they could receive the necessary care. And that's true throughout the city.
And I would add that our 911 dispatch system also has learned to ask those questions so that if there's any possibility of the patient being transported by a family vehicle not contaminating an ambulance, that's one setup. If they're too sick, we have a special ambulance set up in the Worcester EMS system that would transport those patients appropriately. And the CDC was just in this week to inspect UMass's lab facilities because that's really the only piece that we were missing. We have already designated 3 rooms in our 6th floor ICU for this kind of isolation treatment that hopefully would live up to the treatment Nebraska gave to Dr. Sacra.
It's been actually quite nice. I've been in Worcester a long period of time. This has been one area where UMass and St. V's have collaborated extremely tightly because we both need each other to do the best we can to protect our workers as well as to provide care should we have a patient.
Yes, Ms. Spencer.
Sorry. 2 questions. One is regarding UMass's designation to be as a treatment center. Is that as one of the full-fledged biocontainment centers like Nebraska, or is it like the Boston and Springfield hospitals?
Like the Boston and Springfield model.
So there still is just Emory and Nebraska?
And the NIH.
The NIH.
NIH is the only. Okay, the other question is for Mr. McCord. Have there been incidents in Worcester where members of the West African community have been discriminated against or ostracized, and what is being done to help with that?
As someone who's worked closely on the Ebola response in the Liberian community, no, I haven't gotten a case of any report of discrimination against a Liberian in the Worcester area.
Could I ask, what do you guys think the media should do then, if we're not doing it right? What should we do? Educate us.
Well, I think you should report these kinds of symposia and what the people who are most knowledgeable have to say about the disease. I think it's the imagery on the TV media which is most frightening, because it's graphic, it's incessant, and it's been going on a long period of time. So I think reporting as you're doing, the facts of the matter, I think, speaking not necessarily to me, but people who are preparing and who, Dr. Sekra, right, he knows so much about the illness because he's experienced it and he's lived it. It should be quite reassuring to people who read, and people in Worcester read a great deal.
I would say what I noticed, the patterns I've noticed are, number one, journalists should look at, when you're dealing with something as medically complicated as this, I mean, it takes years to become trained to be able to adequately understand the literature and interpret it and turn it into policy. Journalists should be willing to do the research, to have interviews, not necessarily recorded interviews, but really get the information and say, I've studied this now and here's what I understand, and put it out there for people. Instead of always playing devil's advocate. I noticed a lot of people, like in New York, the media flip-flopped so fast. On Thursday, when Spencer got sick, they were saying, he was out there on the subway. He was out there bowling. He was putting everyone at risk. Wasn't that horrible? And they were challenging people, including me, in interviews. Wasn't that terrible? Wasn't he putting people at risk? Wasn't it so terrible? And then the next day, when Casey Hickox got put in that terrible tent in New Jersey, they were saying, aren't they taking away her civil rights? She's not a risk. Blah, blah, it's like, and the same reporters are saying that. And, I think a journalist needs to understand the facts and represent the facts instead of swinging themselves around to make them, you know what I'm saying? Because people hear that person saying on Thursday, he was on the subway, and they think, oh, well, that's an intelligent journalist. It must be true that he's putting people at risk when he wasn't. So I think the media journalists need to study the facts, get the facts, and not represent these
Mood swings.
mood swings.
Can I ask the panel, because I guess we could pile on the media all night, right? I mean, that would be awesome. No. But I would like to do a little critique of the CDC. There are people in the post-election redux that have said that the missteps of the CDC and the handling of some of the early Dallas Ebola cases may have cost the election to swing. There were many, many states that were on the fence. But when you get kind of the cumulative message that the government is not capable or competent or accountable, you get those kind of swings. So I think the wave election that people talk about was not as predictable, in part because some of this, I think, had an effect that people didn't realize. So I wonder if you guys have any thoughts on that.
Yeah, I think the CDC traditionally operates at a 30,000-foot level. They do brilliant analyses of diseases, both in terms of their epidemiology, molecular biology, et cetera, et cetera. They historically have not operated as boots on the ground. I think the CDC made the assumption that if the average healthcare professional can be trained to take care of these patients, things would be fine. What they didn't appreciate was that, the average healthcare professional wasn't adequately trained to take care of an Ebola patient. Why? Because they had never seen such cases, because their practices were adequate for the diseases they encountered day in and day out in the hospital, but not adequate for this particular virus. Now the CDC has boots on the ground. If there's a patient with Ebola in Worcester, there'll be a CDC group here within 24 hours to be observing what is being done. I think that is a difference which will be important. But initially, it was directing from afar, making the assumption that the institutions would do the right thing. The institutions didn't quite know what the right thing was because they hadn't had the experience and the training to deal with it.
Dr. Morse, we can get you the mic.
I don't have a question. I just have a statement to say that this is one of the most, this was a splendid conference. I don't remember being at a conference where there was such focused cerebration about such an important topic. I'm reminded of 45 years ago, this city was dealing with an infectious hepatitis outbreak that befell the football team at the College of the Holy Cross. And we had satellite trucks all over this community, parking and following. In fact, my wife, who's here with us, was pregnant with our fourth child, and she alleges that I was not available for her. I was busy dealing with this hepatitis outbreak. And that outbreak was the first time in collegiate history that the remaining season of a football schedule was canceled because of illness. The next, that was in 1969. It happened again in 1970 when the Marshall football team from Marshall University in West Virginia were killed. 70 people were killed in an airplane crash. I mean, these are astonishing events in the history of medicine and the history of infectious diseases. I learned more about Ebola tonight than I have reading the New England Journal of Medicine, the Wall Street Journal, the Worcester paper, trying to keep up because of the personal impact your stories have on all of us. And I think it was terrific. Thank you. Thank you.
Yes, sir.
Comment. I just think what's happened in the last 6 weeks, what we've talked about, the CDC missteps and everything, the people who have come back or the nurses that have taken care of Mr. Duncan. My comment is, I think it would have been very interesting had all these things happen at the same time as when the normal flu epidemic takes off in the middle of January. And I think we're all lucky, the healthcare system is lucky that didn't happen.
Thank you so much, because that anticipated my unsolicited next comment, and that is everyone in the city of Worcester should get a dose of the flu vaccine. You just don't want to go to an emergency room with fever and chills and have someone say, have you traveled recently, and say, oh yes, I went too, and then be escorted into a room locked in there with people. So please get your flu vaccine.
And I have to say that the city has been very, very interested in pursuing just that, and Derek has worked out with the city school system a massive vaccination day, December 17th and 19th. We're going to try and do what Derek was able to do with the H1N1 crisis in 2009. We're going to try to vaccinate the entire school system, at least the public school system, and the Catholic Archdiocese as well. So kudos to Derek for organizing that with the school system. I guess I'm going to introduce Derek since I mentioned him. Derek is really one of Worcester's finest, a native who has been part of the fabric of the Department of Public Health since 2000, when he started to work there under the tutelage of Dr. Morse, and now has risen to a level of director for the last 7 years and has seen tremendous changes through that department, and I've been lucky enough to be his wingman for about 2.5 years now, and it's been really 2.5 of the best years that I've spent. So I'm very grateful that he was able to come and close this out for us.
Good evening. I'll start off. Dr. Hirsch referenced a quote of Dr. Morse, and Dr. Morse has been a mentor to both myself and Dr. Hirsch over the years, and so one thing he's always talked to us about is if it's predictable, it's preventable. And so we can predict how Ebola is spread. We can predict how to protect our healthcare workers. So therefore, we should be able to prevent its spread and moving forward. And so these forums are so very important to not just talking about Ebola, but really trying to debunk all the myths that are out there. And Moses, I think you hit the nail on the head, and then it was amplified by the group when we really started talking about discrimination and stigmatization, and thinking about all the things that we see on social media. I remember about 4 weeks ago on Facebook, someone had posted a research study that Ebola was now airborne. And so what do you think that did to the community? It's now airborne. And so we're all going to get it. We can't go on the plane. We can't fly here. So we have spent countless hours. And so Tim had called a few weeks ago, which he's done since he's been in the Research Bureau, trying to find things that are happening today that are current and trying to educate the community. And so when he had approached both Dr. Hirsch and I, we said, this is great because this is what we're trying to do. We're trying to get out there and debunk all those myths. So Tim, we appreciate you doing this on behalf of the department, but really on behalf of the community. And so during this, the past 3 or 4 weeks, we've had 2 full-time staff focus on Ebola. Amanda Major's here today, and Seth Peters, who's not with us today, who's actually at a neighborhood meeting to talk about the fact and the fiction around Ebola, because we're seeing this in the community. We're seeing people have been very fearful of what's going on. I think that they've attended at least 40 neighborhood meetings to do just what we're doing here today. So it's great that this would be televised so we can try to get that message out as much as we can. So as far as the state of preparedness in the city, Dr. Hirsch mentioned that we've been working very closely with the healthcare system, with the EMS system, with our first responders, everything from how that individual arrives in the U.S., how they're identified, to active monitoring in the community, and close communications with hospitals and clinics. We have a very strong plan in place, and so if there were an Ebola case in the city of Worcester, we know that very quickly we could identify and respond and prevent its spread in a rapid manner. So we feel very confident about that moving forward. So I thank the panel for doing what you did today. I think it was very informative. It was exciting to hear this, getting the information out there so the media can report on it, the facts of what's going on. That is very helpful. Walter's always out there, and Susan, you're always out there reporting on these 2 items in particular, so we appreciate you being here. And we thank you all for coming here this evening. This is very helpful, so spread the word. If you have any questions, go to the DPH website, www.worcesterma.gov. We will continue to upload the most recent information. It does change. CDC has changed its guidance on a fairly regular basis, and we're following that, and we're updating our protocols as quickly as they are. So thank you all for coming tonight.
Thanks for watching this latest forum from the Worcester Regional Research Bureau, presented on Charter TV3 by Commerce Bank. At Commerce Bank, we're all about community. Our commitment to the communities we serve begins at our front door.